everyone, welcome back to Neurospicy Nursing, another five slide fix, on congenital heart defects. This one is VSD. Let's get on into it. Okay, so VSD is literally just a hole between the left and the right ventricles. Because the left ventricular pressure is higher, the blood flow is going to go from the left to the right. And again, extra pulmonary blood flow is going to cause pulmonary congestion, very common with all these non-cyanotic um, congenital heart defects. And that volume overload, they'll have volume overload in the left atrium and left ventricle. Chronic overload, again, we're going to see tachypnea, diaphoresis when feeding, hepatomegaly, and congestive heart failure symptoms. Um, Large VSDs, though, can cause significant FTT and feeding fatigue. Clinically, VSD is going to give you a very harsh hollow systolic murmur. Small VSDs are going to be asymptomatic, but larger ones, again, CHF symptoms, you're going to see them. All of the tachypnea, the diaphoresis, that sort of thing. And again, it's because of that increased pulmonary blood flow. These infants are also going to have frequent respiratory infections. And long term, if this goes untreated, they can actually end up with pulmonary hypertension. So, treatment options, what are we going to do? First thing, a lot of VSDs can close spontaneously. It's a lot of them are going to close on their own in infancy, but if they don't close and they're symptomatic, we're going to treat their heart failure symptoms. So ACE inhibitors, diuretics, high calorie feeds for the FTTE, just so that they can start gaining some weight. If they do need some sort of intervention, we're going to do transcatheter device closure, but this is for select muscular VSDs. And another one we can do is a surgical patch repair for super large defects in symptomatic infants. Post repair, same as kind of the last few ones that we've seen. We're looking for residual shunting, arrhythmias. However, with VSD specifically, you're going to be concerned about conduction disturbances. I know arrhythmias, you're kind of like, oh, that's a conduction disturbance. Yes, but you're looking more at like an AV block, specifically as a conduction disturbance. Nursing care. So, we're focusing on feeding, their respiratory effort, and conserving their energy. We're going to assess for diaphoresis with their feeds, tachypnea, and we're going to make sure that we're monitoring for hepatomegaly. We're going to auscultate for that harsh systolic murmur. We're going to support them with their high calorie feeds. Also, pre-catheter, same thing, allergies, consent forms, baseline pulses, and they have to be MPO. And then after the catheterization, we're keeping their legs straight if they had a cath, right? Because there's different types of procedures. Monitoring that incision, we're looking for hematomas, any signs of bleeding, checking distal pulses, checking perfusion, watching for those arrhythmias or that heart block, and then we're clustering care to reduce energy expenditure. You're going to see those ones a lot throughout the um, congenital heart defects. All right, parent teaching. Okay. Again, it's hard to hear that your kid has a congenital heart defect, but we're going to assure them many of them are going to close on their own and they have excellent outcomes. We're going to teach our parents to look for all of those signs and symptoms of heart failure. We're also going to tell them just because they had the um, repair doesn't mean that we're not following up with cardiology. We have to follow up with cardiology. And then afterwards, we're avoiding strenuous activity. We're monitoring for fever, chest pain, and palpitations. And then again, endocarditis prophylaxis if we think that they need it. Resources. And that's it. Thank you guys. I'll see you in the next one. Bye.